Hi, happy Friday night. And this is actually going to be a Kahoot that I play, but listen carefully because this is a review for your test coming Thursday. I'm going to share my screen and let me see if I can find my Kahoot. I don't see it. Hold on with what you've got. And I will have it pulled up here in about 3 minutes. Okay, and share screen. And here's my Kahoot. And we will share. And we're going to start this one right here. And let's play. And I'm just going to do a practice because it makes it easier for me to play with one person. Okay, this is Fluid and Electrolytes 102. And this is going to be Miss B. Okay, let's rock and roll. Let's start. Number one, are there ways to test for hypocalcemia? Yes, there are, and how? We as nurses can use a blood pressure cuff and inflate it above their systolic blood pressure, and that's Trousseau sign, and that is what we do to see what they do. They'll do a little flinchy thing. You can stroke the side of the face, that's Hypocalcemia sign, and that lets us know. And it's not only calcium, but it can be magnesium too, so just remember that. For the actual, with the tremoring or the spasming of the muscles. Scanning for renal calculi, it says no, because as nurses, we're not going to just go say, hey, let's go scan them. But if they're in a hypocalcemic state, that means that they have a low calcium in the blood. So they probably wouldn't have renal calculi. You would see that in a hypercalcemic state. And then drawing a CMP is a comprehensive metabolic panel, and we're looking for calcium levels there. We're looking at a bunch of lab levels there in the comprehensive, the CMP. A BMP is a basic metabolic panel, and that's your basics, your sodium, your potassiums, you have your BUN, your creatinine. There are 7 of them that we look at in that. And then when you need extra, you add that CMP. Okay, I have to move my little self real quick. Let me move myself over. And next. What lab values should I know as a nurse? The reason why I ask this is because you need to know your BUN levels, your normal parameters, creatinine, normal parameters, potassium, of course, sodium, of course. You also need to know your mag, your phos, your chloride, calcium, and those levels need to be, you need to know your normal values, okay? I just want you to understand that. First sign of dehydration. Now, I have talked about this. Do we want to test for skin turgor? Yes, we do it. We will pinch. If it is a healthy individual, child, and you pinch and they tint, that skin tense, then we know that they're dehydrated. But it's not the first sign. The first sign is increased thirst. If you start to become dehydrated, you're going to want to drink. You're going to ask to drink. Are there sunken fontanelles with infants that are dehydrated? Yes, they'll have a sunken fontanelle. Is that a first sign? No. The increased thirst is. That is your first sign for infants, children, and adults and elderly. They want to drink more. Even with the elderly, with that decreased drive to drink, thirst drive, they will be thirstier or dry mouths. So we want to watch all of that. First sign. "30 mLs an hour of urine or greater is important when? In any situation, while giving specific medications that are affected by the kidney, what nurses measure and trend for I&Os, or call it MD if urinary output is less than, excuse for the typo, than 30 mLs an hour. All of those are correct. In any situation, any person should have 30 mLs an hour or more of urine, period. You want to make sure they're having that urinary output before you start giving medications that affect the renal function, affect kidneys. So we want to make sure if I'm giving something that I know is going to affect or be affected by levels in the body, by the kidney, the renals. If my kidneys aren't functioning, I can't be pouring in something to a patient, can I? I can't give those patients those medicines, because what am I going to do? I could have buildup of those medications. They could linger longer. I want you to know, anesthesia alone, if you have anesthesia on board in a renal failure patient or a patient with acute kidney injury, those medicines, pain medicine stuff, they last longer. That filtering process and through the system, they're going to circulate out. Potassium's another one. What nurses measure for and trend for eyes and nose, we want to look at our urinary outputs. If it's a 30 ml this hour, 60 ml the next hour, 45 ml, 30 ml, that's low. I've got 2/3. I'd be calling a physician when I got that 30 to say, these are my hourly outputs, urinary outputs, and I am 30 mLs. I haven't dropped below it, but I've got this trend and it's not very much. So what do you think the doctor is going to tell you to do? If it's a volume situation, he's going to have you give them volume, either by mouth, through IV. Somehow they'll get some volume and hopefully it'll pick up their urinary output. If they're just not functioning well and they've got a lot of volume on board, but they're still not putting out urinary output, they'll ask you maybe to do a bladder scan. Are they able to urinate? Is there an issue or a problem, something obstructing? Give a diuretic to help increase the offload, to pull fluid off and into the system and out. I mean, but that is a doctor's decision, but those are the thoughts that should be going through your mind. If a client has a mastectomy, what should you know? Don't take a blood pressure on the mastectomy side. That's a good thing to know. Don't start an IV on the mastectomy side. That's a good thing to know. Explain to the client they could have lymphedema. That's a good thing to know. Do what you want. That is a bad thing. You do not do what you want. You need to understand, we're not going to take a blood pressure on that side. We're not going to stick that side for labs. We're not going to stick them for an IV. And we want to explain to them that they can have lymphedema on that side. And that's why you never allow anybody to do those things to you. If you ever are in a huge bind and the mastectomy is over 10 years old, and sometimes it's a policy thing where you work of how long. Some physicians will say, no, absolutely not, no matter what. Some will say, we don't have another choice. It's been 10 years since the mastectomy. You can stick them for a lab. But I say to you as a student and soon to be nurse, no, you go to the opposite side, find another way. You can take blood pressures and legs. There's things to do. So do not do these things. Follow the steps and you will interpret an ABG. First, look at the pH. Yes, number one, look at your pH. Is it acidic or is it alkalytic? One way or the other, put an arrow towards it. Then I'm going to look at my PCO2. If it's going opposite, then I know it's a respiratory issue. If it's in a normal range, my PCO2, I'm going to my bicarb, my HCO3. If it's going the same direction as my pH, then I know it's a metabolic. If it's abnormal and it's going the same way as my pH, then I know it's a metabolic state. If it's going this direction, it's acidotic. If it's going this direction, it would be alkalotic. If the PCO2 is out of whack, it's not in a normal value, and it's going this way, and my pH is this way, I know I'm acidotic, respiratory acidosis. And if it's vice versa, if my pH is on the alkalytic side and it's a respiratory situation and it's going to be respiratory alkalosis, then my PCO2 will be going the opposite direction. Rome, respiratory opposite, metabolic equal. And I want to say this again, there will be no compensated or partial compensation on the test. I won't do that to you. That is an advanced interpretation of an ABG. That is something that you would do if you went into ICU or dealing with ventilated patients or very, very sick patients, because what the body will do is it's going to try to push itself back into a homeostasis. It wants everything to return to a normal state. And so the lungs and the kidneys together are going to fight hard. And so you might have an abnormal PCO2 and an abnormal bicarb and a normal pH. And that is where you have compensated. The body has worked so hard to compensate, and it's pushed that pH back to a norm. You will not be tested on that. I will not expect you to be able to interpret that. So don't even fret about that. Don't get too wrapped up in that. You've got to be very careful if you're watching other videos out there and stuff, because they are geared towards a more advanced nurse, you know, an ICU type nurse. So you might see it out there. So I'm saying to you, you need to be able to know the pH, drop down to number 2, CO2, put your arrows, 3, bicarb. You should identify those 3 things. Are they normal? Are they acidotic, alkalotic? You know, which way are they going that creates an acidotic or alkalotic state? What is Raglan? If I'm asking this on a review, do you think you need to make a drug card on Raglan? I would say yes. Is it used to ease nausea and vomiting? It is. It's also for GERD. We give a lot of Raglan for GERD, but it does ease nausea and vomiting. Just FYI, should you review your renal function? Yeah, you should, because it can affect the renal function. Does it relieve pain? No. Do you need to know this medication? Yes. And that's why I put it on this review. So look it up in your drug book, look it up in your Clayton, and write out some things, but just know it's what it's used for and what it is, because it is a drug you will see. It's something you give. Does controlled breathing help asthmatics? Yes. If I have an asthmatic that can't get air out, and it is like, and everything's tightening, do I want to use this controlled, focused breathing, pursed lip breathing? Yes. I need to teach them. They need to do these breathing exercises on a regular time frame. It's very important. Yes, pursed breathing can help. Breathing is important for everyone, definitely, and great exercise to teach asthmatic clients, especially children. Let's do these things. Let's make this work. IVs, are they placed using sterility? No, they're not. They're considered an aseptic technique. Central lines are placed under sterile fields, under sterile technique, and arterial lines are placed using sterile technique. But actual peripheral IVs, intravenous access, is not. It is aseptic, meaning I'm not going to touch the end, but I'm not setting up that sterile field and using sterile gloves. I've got clean gloves on. I will clean the site that I'm going to puncture, but I'm not touching everything, then going in, because I know I am accessing a vein. And if I do all that, I'm going to introduce microorganisms in that can create an infection in a vein and cause phlebitis and other issues with that vein. And so it can become very dangerous for the client. So aseptic technique. Also, just FYI, remember when we were learning about taking off dressings for IVs, you want to peel the tegaderm, peel it off. You want to be gentle, but you want to pull kind of towards the insertion site, so that you don't pull out the IV. But once it gets up there, you're not touching that insertion site. You're not, hold that plastic, peel that on off, make sure that you get that, clean the area good, and then apply another dressing. You don't pick the dressing up, touch. It's not about that. It's being as clean as possible as you go over that to prevent infection. It is so important. Potassium, do I IV bolus this medicine? No, never bolus potassium. When you see potassium, think cardiac, and it burns. So things you need to know about a potassium IV drip is it will cause or create cardiac arrest. When you see potassium, think cardiac. We give this to lethal injection. That is part of the lethal injection, is to give a potassium bolus. Never bolus. It is slowly infused, and it is dilute because it burns. Dilute, because it burns. Sometimes patients will go, oh my gosh, I can't stand it. And you've got it going as slow as it possibly can go to get it in the certain amount of time that you want it to get in. The doctor's ordered for it to infusion. If that's the case, then what you can do is slow it down even more, call the physician and say that the patient can hardly tolerate this drip. If that's the case, he can order it to go in slower. They can do a different dilution. Sometimes you change the site, go to somewhere else if possible. The best is to be able to give it into a central line, but it can burn. It is an irritant, potassium. So be very careful. Never bolus it. We know it can cause cardiac arrhythmias. And if you push IV potassium, you will create a cardiac arrest. It can happen. Watch ER. There's an episode I love where she mixes them up. They IV bolus potassium and the patient cardiac arrest that shouldn't have. It's a great episode. They didn't label their medications. They put them in the pocket. They did so many things wrong. This nurse, it was such a good episode to watch. Just saying. Oh, it's the podium. So think about it. You need to know your hyper and hypo, all of your labs, your electrolytes. You need to know BU and creatinine. Please remember albumin. Raglan is a good one to know. We've listed some in there for IVs. The thing I want you to understand is that, it's aseptic. We use them. There's different things that we give IV, and we can have different things happen. And we'll talk a little bit further about it in 103. So I hope you have a great weekend. Continue to study. You've got this. This is an application. You might have 4 right answers. You choose the best and just read it through. You will understand it. If you vomit, what do we have? Alkalosis, diarrhea, acidosis. I will see you soon.